Elbow instability and dislocation. Whenever giving a chance, make a or scroll fortress of stability. Draw the lower smaller triangle, radial radiohumeral articulation, flexors and extensor mass, and outer triangle, ulnohumeral articulation, anterior band of MCL, and lateral ulnar collateral ligament. Then state when there is a terrible tride that both the triangles have been lost and the elbow is unstable. Regarding the patient will come with pain, instability, and clicking. Radial head is covered by cartilage on 240 degrees. Lateral 120 degree contain no cartilage. The stabilizers are as per Odescroll fortress of stability. The primary constraints are ulnohumeral joint, LCL and MCL, secondary stabilizer, radial head, and flexor and extensor mass. Regarding the MCL has anterior band, posterior band, and transverse band. Anterior band is isometric, tight throughout range of motion, most important in the stability against valgus stress test. Insert on the intermedial facet of coronoid, that is sublime tubercle. Posterior band is tight in flexion. Tightness can result in reduced flexion. Transverse band, commonly avulse fracture in form of medial apophysis, associated with radial head fracture, will cause posterolateral rotatory instability. Lateral collateral ligament has radial collateral ligament which attaches to annular ligament. Then lateral ulnar collateral ligament, which is primarily restrained for various stress tests. Inserts on crestus supinaris of proximal ulna. When associated with anteromedial coronoid fracture, will cause varus posteromedial rotatory instability. Annular ligament gives stability to the proximal radioulnar joint. Ulnohumeral articulation buttress effect in the prevention of posterior dislocation. Loss of more than 50% of coronoid height results in instability. Elbow dislocation is mostly posterolateral, simple or complex. Complex associated with fracture. Terrible triad is radial head fracture, coronoid fracture, lateral ulnar collateral ligament fracture with or without MCL tear. Anterior bundle of MCL and capsule attached just distal to the coronoid. Regan and Moore classification of coronoid avulsion of the tip involve 50% or more than 50%. A concept of circle of Huri is important. Injury starts from lateral and goes towards medial. First, the lateral ulnar collateral ligament gets disrupted. Then there is a perched radioulnar joint, and then medial side is involved with medial collateral anterior band of MCL, last to injure. MR arthrogram in stability cases is diagnostic, and capsular T sign with contrast extravasation. Regarding the treatment, in acute cases, usually unstable in extension, full extension should be avoided. In early rehab, you can put a hinge brace if you feel that is unstable. Simple unstable fractures, X-fix, then hinge brace. When open reduction lateral fixation, use posterolateral approach, radial head relocation or ORIF or replacement. In complex fracture, first fix the coronoid. Fix if elbow unstable, suture passed through two drill holes, or posterior to anterior. Lag screw if fragment is large. Medial approach between two heads of FCU. Normally, the lateral and collateral ligament is avulsed fragment from lateral epicondyle and reattached by sutures, anchors, or transosseous sutures. The repair performed with elbow in 90-degree flexion for lateral collateral ligament. And then, if it's still unstable, you can do MCL repair. For chronic, needs open reduction and capsular reconstruction. So you do capsular release, put a hinge X fix. You do annular ligament reconstruction via tricep fascia. Interference screw or endobutton can be used, or figure of 8 through bony tunnels for LUCL reconstruction. Complication, most common complication is stiffness or little Leger's elbow because medial elbow pain in adolescence pictures. And this can happen with it.